Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a very complex and challenging case for you all today, and this is of a patient who attended with bilateral, fully occluding, debris and dead skin, and you can see the contents of their ears. It's very damp and very wet. They've been getting water in their ears, and that's upon the advice given to them by a previous specialist that they saw. And just to give you a brief back history, this patient first had their ears de-waxed several years ago, and they were very impressed by the specialist that they saw at the time. It was pain-free, relatively quick, and it was an instant improvement in the patient's symptoms. And the patient informed me that when they first had their wax removed, that it was a solid lump of wax, really hard and dry. So a year later, they developed ear symptoms again, so they went back to the same centre. But on this occasion, the second occasion, they saw not the same specialist, but I think it was their recently qualified nephew. And unfortunately for the patient, it traumatised them. It was such a painful experience, and he went on holiday the following day, and he said the whole holiday had been ruined because they were that the procedure was that uncomfortable. He said he was sweating bucket loads whilst on the having the treatment done, and that in a way prevented him from, and the treatment wasn't successful, so he still blocked, and in fact the symptoms were worse, and it put him off having his ears cleaned again. But 6 months after that, just think it's a week or so ago, they managed to book in with the same specialist on this occasion, but fortunately the patient again found it uncomfortable, and it was a specialist that they saw the first time this occasion, and they struggled to remove it. They attempted microsuction, and then they performed irrigation, and the patient was there for a while, but it just wasn't successful, and they were advised to use sodium bicarbonate drops and to return. Given that the patient just could not hear, and it was their right ear actually that was the worst one for the patient. That's the ear that they felt was more blocked, and they had more symptoms in because they just couldn't hear it at all. The patient's wife did some research, came across myself, said she just couldn't stop watching my videos online, and they booked in, and they travelled a fair distance to the clinic today to have treatment performed. And it was very obvious upon the patient attending that it was very nervous and anxious because of their previous experience, but they did very well. Now, these are probably the more challenging and complex cases, and let me explain why. First of all, this patient's suffering from otitis externa with inflammation. Otitis externa is an infection of the outer ear, or inflammation of the outer ear. So the term otitis means ear infection, and externa is location. So this is the outer part of the ear. So the outer part of the ear consists of the satellite dish on each side of our head. So we call it the pinna, the ear canal, which is where we are now, and the outermost membrane of the eardrum. So the eardrum has three membranes. The membrane closest to us, so the lateral membrane, that's made up of the same skin that lines the ear canal. So that forms part of the outer ear. Then you've got a middle membrane, which is made up of fibrous tissue. That's what gives the eardrum its strength and rigidity. And then you've got the innermost membrane, which is more medial, so it's on the other side of the eardrum. That lines the middle ear, and that's made of a mucosal membrane. So mucosal membrane, you do get variations of that, but it's kind of a good example of it is the skin that lines inside of our nose, for example, and our throat. So when they've got otitis externa with inflammation, there's limited space in the ear canal. The average ear canal width, it's a range between, say, 5 and 7 millimeters in width. The height between 0.8 and 1 millimeters. I would say in this particular patient, because the ear is swollen and inflamed, the width is probably, and I'm using a fine end suction probe here, so the diameter of this is, I think, 1.28 mil. The normal size Zollner suction probe, which is what I used at the beginning, is 2.1 mil, and that just about fitted. So I would say the width of this patient's lateral part of the ear canal, the entrance where it's most inflamed, it's probably about 3 mil. and then the height is probably about 0.7. So it's just not the instrument in the ear, we've also got the endoscope. So the icleoscope, the diameter is 2.7 mil, and I'm using the fine end at the moment, so that's 1.28 mil. So if you add that up, it's about 3.38 mil, I believe. So we've got very, very limited space in the ear. So we're having to use the endoscope to stretch the ear open. That's a secret, and that's why this procedure is difficult, because it's a very technical procedure. You have to get the endoscope in the right position. You have to stretch the ear by the correct degree. I have to be positioned in a certain angle. The patient's head has to be tilted in a certain angle. And we're using the tip of the side of the endoscope actually to not only stretch the ear open, but to keep it open as well. So it's almost like a doorstop. And then to insert the instrument, we're having to use the instrument at the same time simultaneously to stretch another part of the ear. And this is all done without obviously making contact with the ear canal as we're entering with the instrument, so that would be painful. And then because it's the left ear and I'm right-handed, your hands inadvertently kind of almost cross over if you don't have the right technique. So that's the first technical challenge. It's the ear anatomy and the limited working space. The second challenge is the consistency of this debris and skin. You can see it's wet, macerated, damp, mushy. It's lined the canal wall. I got the blockage, the majority of the blockage off the eardrum already. That's the eardrum there. We can see the posterior part. But you've got all this sticky debris. It's the hardest stuff to remove because initially when I was peeling away the skin near the entrance, that was quite dry and it just came away in long sheets of skin, slithers. This is all mush. It's like mashed potato. And we're literally having to take this off the eardrum and canal wall, but without making contact with the canal wall in particular, because that would be very, very uncomfortable. So if you're new to the channel or you don't often listen to the narration, I always try to describe the ear anatomy in terms of the outer third of the ear canal, which is made up of cartilage and a thick layer of skin, which is about 1 millimeter in thickness, and the inner 2/3 of the ear canal, which is made of bone and which is lined by an extremely wafer-thin layer of skin, about 0.1 millimeters in thickness. And that makes the inner 2/3 of the ear canal very, very sensitive. What I'm doing here on the outside part of the ear canal, you can see I was putting pressure on the canal. I couldn't do that on the bony part. That would just be so uncomfortable for the patient. So I'm actually having to glide across the canal wall to separate this debris and wax from the canal without making contact. And when we're on the eardrum again, now the eardrum is about 0.1, maybe 0.2 millimeters in thickness. So it's wafer thin. And if I penetrate this suction probe in too hard up against the eardrum, it can easily perforate it and it can be very uncomfortable for the patient. Now, when the patient arrived, they said that the second time they had their ears cleaned was probably, it was so uncomfortable, and they were really sure that the specialist was poking and prodding against the eardrum. I suspect not. I think as if that was the case, it's very likely they would have perforated it to the degree how painful the patient was describing it. And I think it was more the kind of jabbing and poking against the canal wall, which is actually more uncomfortable, believe it or not. That's how sensitive the bony part of the ear canal is. It's almost like when you've got a toothache, you've got some exposed nerve, and that shooting pain. And I've had it before, and you can't have anything cold to drink, like cold water or ice cream, because it just exacerbates the pain. It's a similar sensation. I've had people in my ear before who have clipped because the front part of my ear canal, on the bony section, it does protrude out, not massively, but it does protrude out slightly. And when a specialist was trying to insert the instrument into the ear, they clipped that, and it was so painful. And when I've had ear impressions taken before, so when you take a cast of your ear, we put the specialist puts an oto block in, which is like a foam sponge, and you've got a string attached, and that's so you can then later remove it from the ear. I think this is during my training years, and my colleague, fellow student at the time, put a slightly larger than what was required otoblock. So there's a lot of compression. Well, again, it's foam, but it's still, because they have to push it in because it's too large, it's squashed and it's applying pressure against the bony part of the ear canal, and I can still remember that discomfort now. So I've just put some drops in just to loosen this last layer of skin, and we're on the back part of the ear canal, and the drops just help a bit. I was trying to avoid the drops because they've got some otitis externa. I just wanted to keep the ear dry as possible. Now, I mentioned right at the beginning of the video, the specialist that they saw advised them to put water in the ear, and it's fine. That shouldn't be advice we as audiologists should be giving our clients. Water's bad for the ear, and again, that's something I religiously talk about in my videos, and I talk about it to my patients when they arrive. Water can lead to an ear infection called swimmer's ear, and it can do that in two ways. If you have water logged in your ear, so this patient, because of the advice, they used to just dip their head into the water when they're bathing and keep the water in there for several minutes. What that does, the water macerates the skin. So the skin that lines the ear canal, you've got some essential moisturizing factors in there. Essentially, these are oily, fatty secretions. The secretions I'm referring to is sebum. We find that on our scalp. It's an oily, viscous, fatty secretion made up of alcohol, squalene, cholesterols, and long chains of saturated and unsaturated fatty acids. And they are secreted by the sebaceous glands, which are connected to the hair follicles of the hairs that are located on the outer third of the ear canal. And you've also got an oily sweat, which is secreted by modified apocrine glands, also known as ceruminous glands. They are the same sweat glands found under our armpits. So we've also got them in the ear, and they secrete a slightly less viscous, oily sweat. And so these oils and fatty acids that are found within sebum and this oily sweat, they extrude from the outer third of the ear canal via the hair strands and the pores. The ceruminous glands are connected to pores at the surface of the epidermis, the outer layer of skin, whereas the sebaceous glands, the sebum is secreted up the hair root into the ear canal. So these oils then dissipate and they spread, and they create a veneer of film, a thin coating that lines the ear canal and also the eardrum. And these oils are very important because they are slightly acidic, and the acidity helps to prevent colonization and incubation and reproduction of harmful bacteria and fungi. They also prevent external water from entering the skin cells, so the layer of skin that lines the ear canal, and because it's hydrophobic, oil and fatty acids are, and it also helps the skin cells to maintain their internal moisture. So it prevents the internal moisture in the skin cells that's lining the ear canal, the moisture to rise to the surface and evaporate. But if you get excessive water in the ear, what can happen is those essential moisturizing factors, those oils and fatty acids I've just described to you, they get leached, they get washed away. So first of all, internal water in the skin cells, then rises to the surface and it evaporates to temperature, which causes skin to become very dry and itchy. On the flip side, what can also happen is if you have water in there for a prolonged period of time, those oils eventually as I said, get leached away. The skin is hydrophilic, it absorbs the water. The skin cells then swell up because it's absorbed, they overhydrate, and they then burst in the membranes, and you get the outer layer of skin is damaged. It becomes broken, the membranes, it becomes macerated, so soft and mushy. This is what's happened in this case. And both of those things then allow, the acidity is no longer in the ear because those oils are no longer present, and then bacteria can then colonize the surface of the skin that lines the ear canal and then reproduce and create an ear infection. So please guys, avoid water in your ears, and that's why I don't perform ear irrigation or syringing. Now, a lot of specialists do, but the recommended guidelines is if you do, try and dry the ear afterwards. So you can dry the ear in different ways. You get some absorbent ear kind of wicks, which I'm going to get some just to see what they're like. And so they're super absorbent. Someone's like one of these super absorbent kitchen rolls where they absorb moisture. I'm not sure how effective they are, but they are on the market. There's a technique called dry mopping. So dry mopping is when you attach some cotton wool to the end of a correct. There's like a serrated tip, and you kind of swirl it on in the opposite direction, and then you put it should be done under visualization, so it shouldn't be blinded in. Which I was researching something about ears. I can't remember exactly what, and I saw a forum talking about dry mopping, and a lot of people had discussing that they don't do it because it's too difficult or they can't see in the ear. That's after irrigation, and they said let the patient's water in the ear just evaporate naturally. Well, no, that shouldn't be the case, because that patient can then lead to an ear infection. So dry mopping is then when you put that cotton wool into the ear, and you kind of just, normally at the base of the ear canal, you just gently almost press against it with cotton wool so it's nice and soft. Let it absorb excess moisture, and you can go around the edge, and you can spin it if you want as well, but that sometimes can be a bit uncomfortable. But if you've got good technique, it would be good. So an endoscope is actually a good instrument to perform dry mopping with, because you can put the instrument into the ear whilst looking to see what you're doing. But then if you've got an endoscope and you can use it adequately, then you don't need to do dry mopping, because you don't need to use water. You can perform microsuction. So now I appreciate performing microsuction for some people. It's quite challenging. It can be quite difficult. So ear irrigation, I'm not knocking it in that sense, but I just think you've got to be careful afterwards. Another way you can help dry the ear is using a hairdryer. From a distance, of course, you don't want to be right up against your ear. Have it almost at eco temperature, so room temperature, because if you have it too warm or too cool, it can induce the caloric effect. You can get dizzy, and the patient can feel nauseous. Well, not you feel dizzy, the person who's using, like the specialist, I mean the patient. And if you have it at too high a pressure, of course, you can perforate the eardrum. So, but that's another way. There are certain drops you can use or create yourself. So you can use 1 part rubbing alcohol, 1 part white vinegar, so acetic acid. You can put that into the ear. So what the acetic acid does, it helps to reacidify the ear, because there's oils that I'm referring to that are like the thin film of oil that lines the ear canal has been washed away. There's no acidity, so the acetic acid replaces that acidity. And the rubbing alcohol, what that does, it binds to water molecules into a homogeneous solution, and alcohol has got a lower evaporation point, so it evaporates a lot quicker, so it dries the ear out. The problem with that, you can potentially over dry the ear. So there is another type of drops, and it's on our website. We only ship to the UK. I know we've had a lot of interest from abroad, and we are seeing what we can do with that. So if we can, it's to do with, because it's a medical device, and pharmaceutical, you have class 1, class 2, class 3. You have to get the correct regulations in place. But if you're in the UK and you've got water in your ear, or you've got a bit of earache and you've got a bit of inflammation, of course, definitely see a doctor or see ENT in the first instance. But if you can get these drops, it's called Clear Relief Drops. So on our website, there's the URL at the bottom right, www.clearwax.co.uk. Visit our online shop. Our trade shop for specialists at the moment, we have closed that. I'll explain that in more detail as to why in the next week or so, hopefully. But our public shop is still open to the public. The trade shop is just because, I'll just touch on it. So we've just been let down by a company, and so we've decided to cease working with them at the moment. Not at the moment, or permanently. And we're just making other arrangements. The public shop items are all logistically sent by ourselves. So clear relief drops, that contains glycerol and lidocaine. Now what glycerol does, it is similar to the rubbing alcohol. It binds with water molecules. Water molecules are attracted to glycerol, so it homogenizes with the glycerol. Now glycerol actually doesn't evaporate as well though. Glycerol has a higher evaporation point than alcohol and water by itself. So unless the glycerol, you tilt your head and it comes out, it's quite a thick substance. You can drain it out. But what glycerol is, it's an oily substance and it helps to moisturize the skin. So it absorbs excess moisture and it helps to itself moisturize the skin. So it doesn't. So that's an improvement with the alcohol, because the alcohol can completely dry. If you imagine with rubbing alcohol and you clean your hands with that, your hands become very dry. With this glycerol substance, it absorbs excess moisture, it holds it, it carries it, so the swelling can go down in the ear canal, so it absorbs excess fluid in the skin cells that line the ear canal. It reduces inflammation and it kind of holds that. If it drizzles out, brilliant, but glycerol itself, it's an oily moisturizing substance, so it prevents it from drying. And it also contains lidocaine. So lidocaine is a local topical anesthetic. Dentists use that as well to numb your gums and the teeth when they're performing dental procedures. So lidocaine can provide temporary local anesthetic effects in the ear canal. So if you have got a tender, painful ear, it can help. It is a great product. I've had some great feedback on it. So you can get that on our website. Now, whilst I was just explaining all that, we cleaned the left ear. I did a lot more than I anticipated. There was a bit at the front of the left ear in the anterior recess, which I just did not think I'd be able to get because of the small working space in this patient's ear. But we managed to get it. Yes, there's little bits here and there. You know, this procedure, 34 minutes, that's the edited version. There's moments when I wasn't in the ear and I was putting drops in, and when I add it all together, I think the patient's in the chair for about 50 minutes. So it's an extremely long procedure. We normally typically only book 30 minutes. 30 minutes is more than adequate. My normal procedures now, on average, per ear, 4 or 5 minutes. I would say that's pushing it as well. But I still allocate half an hour because I do see a lot more complex cases nowadays, just in case I need that extra time. I don't want to rush. This patient, fortunately, it was just before my lunch break, so I had time, wait through the lunch, it's not a problem. And the patient travelled a long way, so we just continued. So the outer half of the ear canal is all clear, and this ear was more, I think the left side is more technically challenging because of the anatomy of the ear. It was more swollen and narrow. This is more challenging because you can see just how thin this skin is, and it's just not peeling away in long strips. So this skin I'm removing is probably 0.1 millimeters in thickness, so there's very little room and margin for error here. And we're on the bony part, and this is the front part of the ear canal, the anterior canal, and this I find is the most sensitive part of the ear. Not only my own ear, and I've had it clipped in the past, but performing procedures on patients, this is the part of the ear, the front bony part of the ear, that's really sensitive, and I'm just literally gliding it in. It's frustrating in a way because I'm managing to get contact with this skin, but it's just not coming away. It's clipping off in little bits. Now, in the past, there's been some comments, why don't you use, and I've seen the videos online, why don't you use a scoop or some other instrument like a hook to scrape the ear canal and bring the skin in. Now, I just wouldn't do that with my patients. It'd be too uncomfortable for them. It'll traumatize that skin. And even if it didn't, with this particular case, it's not that consistency. It's mushy, it's macerated. It's not going to come away like that. And you can see there, I described it to a patient almost, I gave the analogy, if you've got a stamp on a really dried stamp on an old envelope, and you're trying to peel that away, or if you've got, I mean, that's probably the best analogy, because the other analogy I was going to give, if you've got a bottle and you've got a label, but that bottle is a lot sturdier. An envelope is just a lot thinner. So as you're peeling that stamp away, you want to bring it away, but then you don't want to traumatize the envelope itself. And that's what we're trying to do here. But of course, it's in here, so it's going to be more challenging. And I've just bent the tip of the fine end, and I'm just gliding it now in the back part of the ear canal, right to the eardrum. To be honest, the patient could hear very well at the moment. The reason for removing this is because they had extremely dry, itchy ears. I wanted to remove as much debris as I can. So they're going to, after the appointment, they're going to go to the pharmacy and get some acetic acid spray. That's until they can get to their GP, because then they will need some prescribed medication, most likely going to be Otomize. So Otomize, it's a very popular topical antibiotic spray in the UK. It can work very, very well. Otomize contains 3 active ingredients. You've got an antibiotic, more specifically an aminoglycoside, and it's called neomycin, and these aminoglycosides, they are ototoxic. So if you've got a perforation in your eardrum, you shouldn't be using them. And they end in mycin, so erythromycin, streptomycin, neomycin. There are some examples of them: gentamicin, streptomycin. So MICIN or MYCIN, that's what these medications, group of medications, end in. And what aminoglycosides do, so within the skin cells, or within all of our cells, we've got obviously the nucleus, and you've got other organelles like mitochondria, which is the energy source in the cells. You've got Golgi apparatus, you've got ribosomes, and they all perform different functions in the ear. So we've got ribosomes in the ear, and there's 2 sections of these ribosomes. One section helps to connect aminoglycosides, and the other section, it reads the the DNA code, and it goes off to get different amino acids in the particular order, so that the other subsection of the ribosome can then connect the chain of amino acids to create a protein. So what the aminoglycosides do, so these antibiotic drops and neomycin, it connects to the ribosome, so it prevents the amino acids from being joined up. So if you've got bacteria in your ear and they want to reproduce, they're going to pass on the genetic code within the cell and reproduce via the ribosomes. It's going to tell the ribosomes, this is the genetic code to create more bacteria to reproduce itself. So you need to get these proteins within the skin cells in this order, connect them all up, and of course proteins are made up of chains of amino acids. So the neomycin stops that chain of amino acids from developing and forming. So it doesn't kill bacteria, it just prevents it from reproducing. So it's very likely this patient's got bacteria buildup in the ear, which is causing the swelling and inflammation. So Otomizer's got that. It's also got dexamethasone, which is a steroid, so it reduces inflammation. So because the ear canal is inflamed, especially the left ear, that will work very, very well. And finally, Otomize also contains it contains acetic acid. So what ear calmer has, so it's essentially white vinegar, and it's acidic in nature. Acetic acid is about 2.4, I think, on the pH scale. So it's really acidic. The natural acidity of our ear is around, it ranges between 5.4, I think, and 7.1. So it's generally acidic, approaching neutral. And when you haven't got these oils in the ear, the pH of the ear becomes alkaline, and that then allows certain bacteria and fungi to colonize and breed in the ear. So Otomize is, for this particular case, it's going to be better for the patient, but of course you don't want to give antibiotics to patients for no reason. So quite often acetic acid spray is what doctors recommend in the first instance, because the acetic acid can, as I said, it can also inhibit the acidity, can fight away bacteria and fungi, so it can be quite effective. Advise the patient to avoid water in the ear. I stress that, and not to poke in the ears if they've got an itch. And I know that's easy for me to say, it's difficult in practice, but if you do have an itch, that clear relief spray can help because it's got lidocaine. It will just numb your ear, so you won't feel the itch, hopefully, so you don't need to itch. Acetic acid spray, so what I've described, can also help because that will just help calm the ear, so that could be the cause of the irritation. You can just put some medical grade olive oil spray in your ear as well to see if that helps. There's some sprays out there that also contain tea tree oil, which helps itchiness and irritation. So there's things that can be done. I'm seeing a lot more patients nowadays with dry skin problems in the ear, more well, on par with earwax now. So it's becoming more prevalent, and I'm not sure why that is. I think, well, I was just thinking about my childhood growing up and how much education I had about ears at school and from my parents, and there's very little. I'm from an Asian background. It's very common in Asian families to use cotton buds. I'm sure it's just not Asian families, but we used them religiously in the house, and it was just the norm. But that's bad for you. We used to get water in our ears. We thought it was good. We're washing your ears out, and we felt, or we were made to feel, that if you don't get water in our ears, we're somehow unhygienic. But they're the two things that we shouldn't be doing. And I think we're just not informed from a young age. There's not enough education out there. Patients are getting advised by other specialists to get water in the ear. And so hopefully by watching my videos, I'm changing some habits. So this is the hardest bit, and again, it was so frustrating. I've got that view. It's a beautiful view. I'm so close. It's magnified. I'm on the eardrum. I've got the perfect angle, the perfect bend, but that skin just did not want to come away. It was crusty. It was also clarinetting a bit. I did get a little bit, and I just didn't want to push my luck. So I just decided to leave that particular piece. But there's a bit left here inferiorly, so I managed to get that. You can see I'm using the angle of the sucker to make sure I don't poke into the canal wall. That angle, it almost resembles the same angle, the trajectory of the bony part of the ear canal. So again, it can be frustrating because you do the hard work, you get the skin, you get a suction grip, you're pulling it away, then it flaps back down. So again, I'm just trying to peel that away. I can't move across left to right too much, because if I do, I'm going to bump into the front part of the ear canal with the sucker. So it's only so far I can go with the sucker, left to right, before I'm in close contact. I think that I managed to get a little bit more from the bottom. But it just looks like a complete new ear, even at this stage. So again, just through a bit now. This is not a massive issue for the patient. It's especially that bit on the right. Yes, it's frustrating because it did all the hard work, and it'd be great if I removed it. But you got to weigh up that risk-benefit ratio. It just wasn't worth the risk. I was on the canal. I was on that dead skin. I got access to it, and I'm on the eardrum, and I can't do no more. It just wasn't coming away, and by continuing, I could have traumatized that eardrum, and I didn't want to. I'm very pleased with that. Patient was over the moon. I hope you guys enjoyed it. Take care, keep well, speak soon. Bye.